We might get started, everyone. So welcome to the Victorian Comprehensive Cancer Centre's Monday Lunch Live. My name's Professor Grant McArthur, the Executive Director of the Victorian Comprehensive Cancer Centre. And in beginning this afternoon, I'd like to acknowledge the traditional owners of the land in which we meet, the Wurundjeri people of the Kulin Nation, and pay my respects to their elders, past, present and emerging, and to any of the first Australians who are joining us today, either online or in the room. So the Monday Lunch Live program is a key program for the Victorian Comprehensive Cancer Centre. You know, we're an alliance of 10 members and make a lot of partnerships out around the cancer community, and it's a privilege for us to be joined by you today. And as you can see on the slide here, we've got some wonderful topics coming up in the next month, which I hope you can join us for as well. In introducing today's speaker, it's a little unusual, and for those of you that are astute will know that, in fact, the presenter today shares the same name as myself. And Grant is the Herald Sun's health editor and has actually been working in health at the Herald Sun now for over 10 years. He's received a Walkley for uncovering the cluster of avoidable deaths for babies at Bacchus Marsh Hospital, and I can tell you that that grant has been a very positive thing for the healthcare system, because we continue to refer to that problem to this day. I'd like to share a few personal thoughts about, you know, I've known Grant for quite some time, and you do get to know someone quite well when you share the same name as them and you work in the same general domain of activity. It's interesting in introducing Grant and what he's contributed to cancer and for our patients and our cancer community by actually reflecting back, you know, when I was an intern, which is now about 30 years ago. And back in those days, the media and the scientific and the health professions didn't like to mix. You know, we were really brought up as youngsters that you can't trust the media. They'll distort, you know, what you have to say. If in fact you went and tried to publicise something of great interest to the public through the media, you were seen as self-serving and not to the benefit of the learned academic community. So how things have changed now, and of course we all know that health stories and science stories are the most popular things for the public to view and read and be interested in, and you know, our speaker today has contributed to that change in culture. I've got to know, you know, Grant well. I'll have to share that with you, that having worked with him on many stories, in nearly always involving individual patients, that he really approaches his role as a journalist with those patients with utmost integrity and care. If I say, sorry, we can't go there, he absolutely respects that. And you know, Grant, I think the way you perform your role as a leader in healthcare communications is exemplary. Now, I have to, of course, make some comment the fact that we do share the same name. The most amusing one was when I'm sitting in my office at Peter Mac in East Melbourne a number of years ago, and my phone rings, and I pick my phone up, and who is it but Grant's father, ringing him up to wish him a happy birthday. So I was able to actually just share what I just did with you, and that is, you know, what a fine young man he is, and that and he should be very proud of his son, and he better try a different phone number. Needless to say, we've received each other's correspondence and phone calls on numerous occasions over the years. Probably in finishing my personal reflections on interacting with Grant, you know, I might share with you the countless times colleagues have said to me, "Gee, I love that article you wrote in the Herald Sun." And actually, they were genuine. You know, they thought I wrote the articles, and so I think, you know, that says something about the credibility, Grant, of the way you write. That you know, people weren't just slapping me on the back and jesting with me. They genuinely, you know, were thanking me for writing, you know, high quality articles. So I think that says a lot about you, what you do. So what Grant will talk to us today is about the media's role in connecting the public to the work of clinicians and researchers, with the title of How the Media Treats Cancer Daily. Over to you, Grant.
Thanks, G1. So I'll like to chat today about, I guess, my perspective from my side of the fence, which is obviously a very different perspective probably to what you all have. Essentially, why we're interested in cancer, why we're interested in health reporting generally, and why we think our readers are, which is very different, I guess, to what a lot of internal publications are, probably what the view is from the other side of the fence. Actually, it's interesting with G1 talking about how people have thought he's written stories. I had one of the most bizarre press council complaints of all time lodged against me. I would like to say a very rare one, when the solarium industry put in a complaint about how I was writing all these stories trying to get solariums shut down because they were causing skin cancer and failing to acknowledge the fact that I was actually an oncologist and working against it. It was the easiest one anyone's ever defended. Which is why I can't understand why people would possibly think that I'm a professor. Actually, I should ask with the whole G1, G2 thing, Annie Raleigh, who I see is here today, years ago she was working at Peter Mac and she came up with the ingenious code of calling us G1 and G2 when things were getting a bit too confusing. Unfortunately, after Annie left, one of her followers didn't continue following that intricate code. And I remember sending in a question, which was a typically stupid journalist question, where one of my editors, or then editor, had a news tip that something big was happening at Peter Mac and it was slightly controversial and so on. I needed to ask questions. It's one of those ones as a journo, you think this is going to get embarrassing, but I better call. So I called up. Look, this must be happening. Can you please look into it? Well, no, that sounds pretty stupid. Well, no, I'm assured this is true. We need to look into it. And to her credit, the PR person at the time, I know damn well that she did look into it. And the reason I know that is because when she sent an email to all the heads of department and senior clinicians asking about it, she copied me in on it, thinking I was the other Grant. And so I knew the email had gone out. So that was a bonus. She got a very big tick in my book for following it up so promptly. Tick sort of disappeared when I read the body of the email, which went along the lines of, hey, everyone, got a really stupid request from the Herald Sun. I suggest nobody respond to this, but if you do know any information, come and tell me about it and we'll see what we can do. To which I obviously just replied, that's fine, I agree with you. It is a bit of a stupid request, but I have to look into it. The other thing I have to acknowledge, so this lovely tweet went out the other day and an ad for the talk today, and I put a bit of a smart response saying about the dashing young man in the photo, because I reckon that's 4 or 5 years old. Now, the reason I was having a chuckle about it is I kind of forget what I'm looking like now, because it's only about a week ago and I was looking like that. So when I saw that photo, I kind of thought, wow, I haven't looked like that in ages, but I did kind of go and lock the hair off, having met a milestone I was trying to do where I refused to get my hair cut before I'd got there. Just joking about not being a professor and so on, it does make me think about what my role is day to day. And essentially my job, I get up in the morning, I go to work, and I come out and chat to folks like yourself, and I get to be the dumbest person in the room I walk into every day. And I celebrate that. I mean, today I come in here, I'm not even the smartest Grant McArthur in the room. So it's something you live with as a journo. You go along, you can't possibly be an expert in every field you walk into. talking to you all about cancer-related things at the moment. When I get out of here, I have to go and do an interview about obesity. Later on, we're in election mode. No doubt I'll be on the phone half the night talking about election things coming up. It's just the way it goes. You can never be an expert on anything, and quite frankly, as a journo, you shouldn't be, much to the annoyance of those people that you're interviewing and chatting with, because they're on a whole different level. And why do they want to chat down to a journalist who doesn't understand it and clearly isn't at their level? But I kind of celebrate being the dumbest person in the room, because if I can go in and chat to you all and ask enough questions so that I can grasp what you're talking about, that means I can explain it at that level to readers. And at the end of the day, that's what my job is. It's to take the wonderful things you're all doing and the wonderful things everyone's doing and the stories that heartbreak that people might be going through, to put that in context so it can benefit other people. If I come into it with preconceived knowledge, I might miss something and miss the obvious, and I don't get to convey that message. So coming at it from a point of ignorance is actually a blessing in my job. Years ago, I made the mistake. I'd been on the health round about 5 years, thought I knew everything, and in some instances, I was starting to pick up things. When you've reported about something on and off for months, you actually do start to pick up a bit of knowledge. And I started realising I was doing an absolutely terrible job. The amount of stories I was writing where I was explaining what the latest breakthrough was, and I was saying this, and this has happened. Look, I might say X, Y, Z might have happened, and Z was the new part. I was only writing Z, and I was never putting in my articles that X and Y had come before it. And so poor people picking up that story and reading it for the first time weren't getting the full context of what it was. It was probably completely untouchable for them to understand it. So as a journalist, I guess that's just me explaining why I am stupid and why I annoy you all and why I get to be the dumbest person in the room. But it actually is a good thing. If I come into the room and I don't ask silly questions and I don't get it at the base level, I'm not doing my job and I'm not explaining it to people. Of course, that does go pear-shaped sometimes. And this story here doesn't relate to cancer, but it is one that will live in my memory forever. And it got raised last Saturday night over quite a few wines too, with the person on the other end of it. But this little boy, Isaac, he was born with a condition called scaphocephaly, which in Latin just translates to boat head. And the fuses in his head weren't shaped quite correctly, and his head was growing long and thin, and he was in all sorts of trouble. But there was this amazing surgery, and it was one of the most amazing things I've ever seen. And it took me weeks to chat with the surgeons and the people at the Royal Children's and convince them that I was up to doing the story and doing justice to what they were doing. Then a photographer and I met with the family. We travelled to Shepparton. We sat through the surgery, which was pretty amazing. We watched them essentially take this child's skull off, peel his face back, take his skull off, in quite brutal ways, hack his skull into little pieces, reassemble it in a different order like a jigsaw, put it back on, stitch him up and send him out the door. Absolutely amazing to see, and an absolute honour to be able to witness something like that. Fast forward a week and they're taking the bandages off his head. And the surgeon had been wonderful to have this amount of attention, and deservedly so, focused on his work. No one had ever been able to do it before. He came past and we were taking this photo. It just happened that the day his bandages came off happened to be his first birthday. So we do what we like to call a hero shot, and we got a birthday cake as the bandages came off his head, and we did it. Now, as we're shooting that photo, the surgeon happened to come down the corridor and saw it and got really angry, to the point where he physically jumped up and down and banged his hands, and he was saying, "I knew I shouldn't have let them come in. You're just making it look like a dumb, happy story about a kid who was sick and he's now better and he's going home." And I kept trying to say, we're actually going to quite a lot of trouble. We are going to do this story justice, but he wasn't keen on it. Get out of my hospital. And we had to leave. Fortunately, it was only a week till the story ran. And when it did, we did run that story up on page 3, and it ran really big, beautiful photo. But if you look at the bottom of the story, it's actually got a pointer to back further in the paper. All of this part here. And that was the part he missed, where it was a leap of faith, but we did run quite a big piece on it, and we went right through the intricacies of how they had cut up this boy's head, reassembled it. We've got graphics there explaining it. And that's what you can do when you do have people trust you and you do go through it. Now, the beautiful part about that was I got a very big apology sent to me by that surgeon saying, oops, I was wrong. You actually did do justice to it. So it's a lovely feeling, but sometimes you just do have to have that trust, and it goes both ways. The trust for them to let us into the operating theatre and to follow a patient in such detail. But the media also has to meet that trust and come back and do justice to it. Instead of running a cute little cutesy photo of he was a little boy and he's now better, you actually, if you can get the chance, go for it. And I'd encourage you all to do that. This is a similar sort of one where it worked in a cancer context for you. Now, I got really frustrated. I'm a bit of a nerd, and I get fascinated by medical research. It's one of the most wonderful things. Not smart enough to understand it, but that's the challenge in it, and that's why I love it so much. There's been so much reporting about immunotherapy lately. For the last few years, it's dominated what I look into in research, but it's really hard because I get 350 to 500 words maximum for a lead story in the paper. And generally it's not 500, it's more often 350. If you're dealing with a story that has a new breakthrough, you can barely summarize the abstract of a paper, let alone give background on what it is. So all these stories about immunotherapy driving me insane that I can't explain what it is. And everyone's reading these stories. I don't think Joe Bloggs in the street has a clue what immunotherapy was at that point. So fortunately, there's enough people at the VCCC here who had some trust in me. So we came in and it probably took a week or two and chatted with a lot of people who had to talk way down to me, and they did it brilliantly. And instead of that story ran on page 9, which is about one of the latest breakthroughs that's happening, not overly digestible, it only manages to touch on it, but we could then inside run a much larger piece explaining all of the intricacies of immunotherapy and so on, give an update on where it is in that time, exactly what, well, not exactly what, but a touching, a toe in the water about what immunotherapy is, where it's come from, and where everyone hopes that it's going to go. So that worked really well. And again, that's an example of just having that trust both ways so that you can do a better job for everyone. Again, that ran on page 26 and 27. So it's back in the paper, but that's why we have such a meaty news story up front to grab people's attention so that you can point back with the more value story. And as well as a lot of text on there, is there anything else that sticks out to you that's on the page? Roughhead is on there, which actually, another funny story, when I was writing this story, I had to call Hawthorn Footy Club to say, can I get Grant McArthur to talk to me for this story and talk about treatment of roughhead, of Jared. Now, the funny part was when I called Hawthorn, they got very confused and actually thought it was the other Grant calling to say, can I talk to the Herald Sun? And things got really ugly. But that was kind of a bit confusing when Hawthorn thought that I was imitating a doctor, who I wasn't. But the thing that sticks out to me on that page is actually Kerry, which is the lady in the red up there. Beautiful, big, happy, positive story, because as much as there's a lot of text there explaining why immunotherapy is important, none of those words can capture why it's important like her. I mean, she's alive, she's happy, she's healthy, and it's because of what's going on in those words. And I think that's the most important thing, is nothing should be able to underestimate what the power of humans are. Health reporting, medical reporting, it's about people, it's about people's health. So whenever we're doing it, we want to have humanity involved. I can throw at you 100 different statistics and 100 pieces of evidence on why something's important. People's eyes will glaze over. They're not going to read it. They're not going to switch on. You put in a human face in there that could be that person, could be their mother, their sister, their daughter, and people suddenly take notice, and then they read the 100 points because it's relevant to them and they can see their way through it. As far as human faces go, if anyone wants to doubt the power of it, this is the story I think that sums up for me more than anything. Probably one of the most powerful things I've ever seen in reporting. I don't know if everyone knows Claire Oliver, but Claire did, there was a story about Claire, I think it was on the 7:30 report one night, and then I went in and met her the next day, and thanks to Grant and Annie and everyone for helping organise it. But this is actually a piece written by Claire on her deathbed about how she had cancer from solariums. Now, people had spoken about the dangers of solariums. You almost wouldn't have even seen the reports. It did nothing. People's eyes glazed over. Claire, on her deathbed, spoke about why she was dying, why she shouldn't be dying. And it was a hard day. Claire was on oxygen, so she'd only get half a sentence out. She'd have to put the bottle back on. We just recorded what she was saying, went back, pieced it all together and typed it out. And I don't know, that Claire only lasted another week or so after that. She had a birthday. It was wonderful. Everyone jumped on board. It built up momentum. And as a result, Victoria banned solariums. You can't overestimate the power of what things, you know, of doing good. If you get messages out there and you do it properly, it makes a difference. Another, again, this isn't a cancer story, but it's another one I like to look at in terms of doing things right, how the media can make a difference in health. I and a lot of other media at the time, going back years, were getting a lot of stories about children missing operations at Royal Children's Hospital. Basically cardiac patients, one after the other, and there was lots of little stories about how little Jimmy missed his operation, and they weren't taking much notice. Chatting to a lot of people, confidential sources, I was finding out that the problem was actually not that there wasn't operating theatres, there weren't surgeons. In fact, they were getting very frustrated because they're ready to do surgery, huge waiting list. There wasn't enough beds in intensive care for the children to recover in. If you don't have an intensive care bed, you can't operate. So took a bit of negotiating, but I somehow ended up with a surgical list that listed, I think, 63 children who'd been bumped from surgery. Through intermediaries, we contacted a lot of those families and said, is anyone sick of this? Do you want to do something about it? A lot of the families met us. We hired out a photo studio and we set up portraits with all the kids who were missing out on their operations. Very, very non-subtle front page saying, save us. Inside, again, we go on the human face and we run a story on each of the children, why they need their operation, why they're not getting it, and what the consequences are going to be. The next day, little Lincoln, unfortunately, overnight when that came out, he arrested that night, got rushed to hospital, got the surgery he'd been waiting for ages, but got it as an emergency patient. So the next day we ran a front page with him, basically purple on the front, saying, have a heart, why aren't you saving these kids? The then health minister went to the hospital to try and broker a, you know, what can we do about this meeting, but was refusing to talk to us. I went to the hospital and actually stood next to his car so that when he came out from the meeting, he had no choice but to talk to me. After a week of that, we got a whole new unit, intensive care unit built at the Royal Children's. I think they trained 27 nurses up because that was one of the problems. They didn't have enough intensive care nurses to even operate the beds. So it made a huge difference and worked really well. Another one, Ron Walker, who just can't speak highly enough. I've dealt with Ron a lot through politics and through other reporting. One of my colleagues did a story with Ron, who knew him quite well when Ron was first diagnosed and went and got treatment. He didn't want to talk about what was happening to him, which was fair enough, but very private, and he didn't want to look like he was big noting. It was also, I think, quite hard because he'd been able to get treatment when a lot of other people hadn't. And so had a chat with him and said, I understand you don't want to talk about your own treatment, but there's a lot of other people who can't access this. And he'd already been thinking that, and he wanted to do something about it. So we got to talking, and he decided, no, I'm gonna push really hard. So we did a bit of a story. Ron went and he went and knocked on doors. He met with Tony Abbott, who's the Prime Minister then. He met with the drug companies and pleaded with them. He flew up to Sydney and did a very, very emotional speech to them. They were all crying. They simulcast it and put it out to all their offices to show the people manufacturing these drugs and pushing it, this is why we need it. And people started listening and, yep, okay, so Keytruda, Opdivo, they're probably going to get listed. But it needs to go further than that, because the hold up is a lot of these drugs are kind of in purgatory. They're in limbo. They're all getting proven, but the time taken to get them through to patients who need them is horrifying. So again, we took it a step further and we went and got a lot of these people waiting for these drugs. And instead of putting it at one, we ran a story about all of this. We've listed 36 drugs that are all waiting. And we didn't just say they're waiting on these 36 drugs. We said these 36 drugs are emblematic of a much wider problem, because people, they can't access any of these because of the system. So there's no use trying to make us go away and putting down these 36 drugs. What you need to do is reform the system. So while you're evaluating those, people who need them can still get them. I think that made quite an impact. Now, a lot of that went on. Again, you see the human faces. One of the most beautiful things was actually the young girl up there with her mother. About 3 or 4 weeks after this article ran, she wrote to me, and then she called up crying because her mother had actually just got the medication, and that meant months of extra life for her. You can have good days, that was one of them, but there were much better days we never hear about, because a lot of those medications got through a lot quicker, and hopefully a lot of your patients benefit from it. They're great stories. They can't all be like that. And this is probably the part that annoys a lot of you. We have a thing in the paper. We all want to write stories that change the world, but you need a mix in the paper. We call it light and shade. But if you've got some grisly murder on page 1 and double spread inside about a horrific fire that's killed a young family, you can't just keep having bad news everywhere. You need light and dark. And I understand that it can drive people to distraction. There might be a world first piece of research that's come out that day, and we might run it on page 14, and everyone looks and says, why is there a story about jeans being too tight on page 3? The difference for that is you have to look in context to what was on the other pages around it. You can't just keep smacking people over the head with bad news. Sometimes you need a light story to break it. Equally, if you have a lot of light story or a lot of politics that's driving people to distraction, there's nothing better than having a quite intelligent piece of research there to make people think a little bit in between all of that. So it's about getting the mix right. It's hard for people outside the industry to sometimes understand. And this story actually was probably always going to be a walk up for page 3. This is about a girl who was found in an Adelaide park. She couldn't walk and she had no feelings to her legs, and she'd collapsed because her jeans were too tight, because she had these hipster jeans on that had cut off her circulation for hours, and she was in a very, very bad state. It was actually quite a serious medical one. The interesting part about that, so that's page 3. If you look page 6, I've got another story that's probably a much more likely story to change the world. That's about, they've uncovered the reason why a superbug had killed 18 people, essentially at St Vincent's Hospital. Quite an important story, yet one ran much further back in the paper. And even more so, page 9 is then a story about the need for blood transfusions to save beautiful little kids like these guys. Again, to push it even further, I'm looking at people almost dying because their jeans are tight. I actually put in a request and did proper research into how many people were ending up in emergency departments because of accidents with their clothing, which ran on page 3 again. And there's instances there of people becoming unconscious because they've tripped over their undies and hit their head on the wall. Other wonderful earth-shattering stories like that, which is on page 3. And yet on page 6, my colleague Lucy Vandenberg has a wonderful story about a girl ending up in a coma and the dangers of sanitizer, hand sanitizer, that nobody realised. And again, end of fasting for surgery, which ran on page 9. Those stories, if you're going to look at it in terms of changing the world, they've probably run in completely the wrong order. Yet, I'll back the editor any day of the week, because I've seen the rest of the paper that they ran in, and that is the order that you needed them in, because there was a hell of a lot else going on around that. Yeah, aside from, while I'm frustrating you all and showing how badly we sometimes run stories that you think may want to go in the other order, I did actually do some homework before I came here, which is unusual for me. But looking at that, I understood, well, hang on there, we've run 3, and that's pretty normal, running 3 health stories, medical stories in the paper a day. We do a lot of work. And I thought, I wonder how many stories I actually do write. I never really look. And I also had a look at how many cancer stories. This isn't probably the most scientific scientific analysis going around, and I doubt it's going to get up through peer review, but I've done it. I put my byline into the system, and I've written just on 3,000 stories in the last decade or so. 430 of them contain the word cancer. 48 of them had the word Peter MacCallum Cancer Centre, 38 Cancer Council Victoria, 27 the University of Melbourne. This is all cancer and these words. 38 with the words cancer and state government, 23 with the words cancer and federal government. So if you look at that, that's essentially 1 in every 6 or 7 stories I've written for the past decade is about cancer. So that underlines how much we write about it. We write about it that much because the public cares about it that much. When I do a bit of further analysis, I notice heart came up 428, so only 2 less stories about heart disease over that time as cancer. I think that if you look at the nation's biggest killers, it's pretty understandable why they're neck and neck. Obesity 147, diabetes 119. So I think you can actually see the emphasis that we put on stories actually follows the path of how these things are affecting us all. My 2 greatest loves in covering this round is looking at research and surgery. I absolutely love it. Any chance I get to go into a research lab or a surgery, I'm there. They came in at 489 and 453 mentions respectively, so clearly I'm pretty split on that. Slightly less satisfying when I went through it. I thought I'd probably crucify myself here, and I typed in the word miracle to see what happened. And under my byline, unfortunately, it came up with 85 mentions of the word miracle, which is something that really annoys everyone when you take their work that they've been working on for years and years and years, and it just gets, oh, it was a miracle, that's why it happened. It wasn't all the hard work, wasn't all of that. I will hope you notice, I've cut out a few here just to completely crucify myself. In almost every case, the word miracle actually appeared in a headline or in a quote from somebody, so it's not necessarily something I write. I also noticed that most of them occurred around the 2010 to 2012, 2013. So I'm assuming we had a sub-editor or two who has now moved on, who was very much into miracles. It was interesting reading it. I did think maybe I should change my byline to Saint Grant McArthur, which would have been probably outdoes Professor for the first time as well if I did that. Yeah, much as that's interesting to see. I think there are rules for good reporting, no matter how much you want to use hyperbole and build things up. There are rules on how you should tackle medical reporting. You do have to be responsible. There are things we need to do. And I think most importantly is if you can't provide the evidence for the statements you're making, you can't put it in. You've got to leave it out. Everything has to be evidence-based. It's the same as when you're in a research lab or when you're treating a patient at the bedside. If there's not an evidence base for it, you've got to leave it out. And it's the same when we're reporting. And I think the easiest way for reporters to take note of that is that when you're writing something, you almost need to be able to provide the breadcrumbs through that story. It's like an iceberg. We may only be able to touch on the top of it, but if you can provide the pointers so that people could read the story and go away, and you've cited the medical journal, you've cited the researcher and the centre where they're doing the work, people could hopefully be so entranced by a article, they would go away and look it up themselves. And if you've provided all of that, and people can go away and look it up and see that what you're writing is accurate, no one can criticise you for that as far as I'm concerned. It also means that those people who don't feel like going away and doing more research, which is most people, what they're reading is accurate, fair and legitimate, and they're going to be better for reading it. So I think that's the most important thing that you should ever do. The other part about that is self-protection as a journalist. I find that if you follow all the rules, it's very hard for people to criticise you. When we do get criticised, mainly it's because the people who are reading it, the researchers, the research centres, don't like the emphasis we've put on things. And I get that. And they don't like the order we've put things in. And it's a very hard concept to explain, but we are essentially writing for a very different audience. We're writing for people to read who have never been near an operating theatre, near a research lab. Hopefully they've never been near a bedside with a loved one who is dying. Unfortunately, too many of us have, but we're writing for that audience. and it's a very different audience to when you're presenting a journal for somebody and the attention is on you. When we write something, we have to figure 3 main audiences. There's the talent, the clinician, the research, whoever it is that we're interviewing who's contributing to that story. There's my editor who's going to place it. I need to think about how do they want to place the story. But there's also the reader who's going to be reading it. And out of those 3 sometimes competing, most of the time they're fairly harmonious, but out of those 3 things I have to think of, the reader's the most important. They actually come in first, second and third. Whatever I'm writing, no offense, but if I interview you and I get your information, my job is to translate what you're saying to a reader. It's not to put you on a pedestal, and it's not to sing your praises. Hopefully that will happen anyway. But it's to cut through and get that to a reader. And it's a hard one to get around. Sometimes people don't quite get that. They get annoyed, and that's why it's important to make sure that when you have that conversation afterwards, you can say, I have cited your research, I have explained why that's at the top of the story, and it is all in there. And you need to cover yourself, and you need to protect those people you are speaking to by making sure that all of their information is in there, even if it's perhaps not in the order they prefer. I find generally that when I do get criticised in that way, most of the criticisms I have, I've actually done my job properly. It's because I've dumbed things down enough so that people can understand it. It causes friction though for all of us. The other one that can cause friction, I actually had a bit of, I'll wind up here, but I've actually had a bit of in the last 2 weeks, I've had a bit of feedback from readers, and this is the other one that can be tricky. I had a letter from a reader the other day criticising me in no uncertain terms, and legitimately from their point of view. I'd written a story, and in it was about cancer research and the need for doing something, and in it I'd mentioned the survival statistics for this particular cancer, and they weren't great. And I had somebody who had a loved one with that cancer writing to me in no uncertain terms, not happy because how dare I put those survival rates in, because that was very, very hard for them to hear. And do I understand what the impact is on that person and everyone knowing how unlikely it is that they'll be around for much longer? And that's pretty tough to hear. And I mean, there's not much you can say to somebody in that situation. The problem is I do have to look wider, because I know that when we write those stories, the public becomes more interested, and the push to get more breakthroughs, more research dollars, more attention for that form of cancer in the long run will help the next people that get diagnosed with that. There might be better breakthroughs for them. There might be more funding to find the next generation of breakthroughs, and hopefully those survival statistics will go up. That's looking at things on the wider level, but on the medical and health round, it's bloody hard not to look at it on a personal level as well. Which brings me to the last point, is that cancer is personal. I had the second letter I had in the last week or so was having a crack at me, because again, it was a type of cancer that we'd linked to obesity, and if someone was saying if you went to a hospital ward and had a look around, you'd understand that this isn't just obese people. I do understand that, and with that cancer and so on, again, it's putting information out there. It's very hard to hear, but I had somebody daring me to go into a cancer ward and see what I was doing, and it was very hard to not write back, because at the moment, and one of the stories, a part of the reason poor G1 gets bothered by my father is because my father has skin cancer, and he's a Peter Mac patient, and he was back then and he is now, but it is personal. I think all of us know people with cancer. The story down the bottom there about the wonder drug, which probably gets everyone annoyed, but my father's actually on that, and that is a story about this amazing breakthrough, and how there's been 4 people with complete response to that out of a trial where they've had 28 responders. I'm fortunate my father is one of those people who had a complete response and wouldn't be here now without it. He shouldn't be here. He should be dead. He's not, because of this research, because of that. I do understand it, and I do understand how personal it can be. That's the way it is, I guess. So here's a chance for revenge if anyone's been interviewed by me or anybody else and had to put up with lots of journo questions. Fire away.
Thank you, Grant, for finishing on that, beautifully personal touch there. I think, that's what drives many of us in the room, are those personal experiences with our patients and the patients that inspire us. So thanks for sharing that. Now, I think Mark Rosenthal has his hand in the air. If we could get a microphone for Mark, please.
I have been to the last question. Tell me how we've got to the situation with medicinal cannabis. So medicinal cannabis, as an oncologist looking after brain cancer, this morning I had 2 patients out of 10 wanted to go on medicinal cannabis, and I have the same conversation every week. And I just wonder how the disconnect between
reality
society and government for investing in it. How there's such a disconnect with the science and the scientists?
Yes, I'm not a politician or a scientist, so I have to tread very carefully here. I guess I try to sit between the two, and I get extremely cynical. I speak to enough people to know what the evidence base is, and it does seem extremely out of whack with where we're at the moment. I also know that when there was a debate about whether medicinal cannabis should be made available, I was lobbied. I'd be getting 5 or 6 calls a day from 5 or 6 different sources. Well, allegedly different sources. I think there was very strong links between a lot of them. There was a huge lobby. It was a political push, I think, based on politics much more than science. But I also, as cynical as I can be about that, I also have seen enough of these to know that it will level out, I suspect. Medicinal cannabis is the buzzword. Everyone's talking about it here and overseas. Once everyone has a chance to see how it works, I'm sure that will also work its way through, and perhaps its usage and the attention focused on it will be much more in line with where it's proven to work, and more in particular where it's proven not to work.
It's just an example where the scientific method has just disappeared. So that a friend of mine told me that this is good and it can be shark cartilage or B17 or any other.
Stem cells.
And just this disconnect.
Again, this is one I should have typed in the words medicinal cannabis with my byline. I reckon I'd find 3, 4 bylines tops. I've tried to keep out of that debate, simply because it wasn't one where I saw it going where it perhaps ended up. Yeah. I haven't answered your question. I'm trying to be a politician here.
We're a political reporter for a little while.
I was actually. I should mention that after I decided that I was doing a terrible job because I started getting a little bit of knowledge. I was actually missing stories because I would have people pitch a story. I'd look at it and go, "Yeah, I've already written about that. I'll leave that alone." Then I'd read it in The Age 3 or 4 days later and go, "Wow, that's a great story. Why the hell did I pass that up?" And I'd realise it's probably 2 years since I'd written about it last, and a lot had changed. So I decided I knew too much, so I ran away and did politics for a while, became the most cynical person on the planet, and came back to deal with real people.
Yeah. Thank you, Grant, for the presentation. Thank you, girls, for Mossel Institute for Global Health at Herald University. A question for those of us working outside the cancer and children. Often it's very easy to engage with media, to get a story out there, or to bring that change, and you're very good at facilitating that. So in the preventative area of public health particularly, how do we get those stories out? I mean, maybe one is a great example for the Solarians, for example, but other examples, other ways that those into preventative health outside the topical or fashionable areas can get message out.
Yeah, thanks. One of my biggest frustrations in the past decade has been seeing the little attention given to preventative health, and it's a hard story. It's the same. I guess you look at it as the same as a politician. It makes sense to put money in preventative health. Every time you put $1 in, you save 100-fold at the pointy end by not having people in a hospital bed. But when you open a new bed, you can cut a ribbon on it before an election and say, "I've opened up a new bed." You can't say how many people you've kept out of it by providing that other $1 earlier on. Unless you keep statistics over a decade, you can't prove to the world how wonderfully you have spent their money, so it doesn't get spent. It's the same writing a story. The data isn't there for it. I did love, without delving into politics, it's just the example I can think of. couple of governments ago, they started the Healthy Together Victoria program, and they saturated the grassroots communities with all these preventative health dollars. It was a really hard story to sell. And so to make it interesting, we actually went around all the country communities and we got the first lot of data on how individual communities were benefiting from all this. And I looked over them for a couple of months so we could find all the communities with all the different indices. So we had the most obese part of the state, we had the one with the highest range of diabetes, the lowest fruit and vegetable consumption, highest rates of alcoholism, presented all of these, worked over it for a couple of months, worked up this great big package of stories, running it in the paper the next day, and we finally found a way to make a very unsexy topic quite sexy. At about 6:30 that night, as the pages are being drawn up, and it's looking wonderful, Molly Meldrum fell off a ladder and banged his head and ended up in a coma, and the paper got ripped up, and I had to write the story, well, got to write the story about Molly. I love the guy, he's great, but my story got shunted to the back and made quite small, so poor preventative health, again, got sandwiched. It's a hard story to tell. If you've got a great way of telling it, we'd love to hear it because it does need to be out there more. We do talk about it a lot, particularly in terms of obesity, chronic disease. It comes out there, but it's a real slow burner. It's very hard.
Grant, could you just following up on that great question. So the Claire Oliver story, I remember we were, literally banging our heads against a brick wall with all the available data about solariums and as a preventative measure for banning slims, a preventative measure for skin cancer, and then all of a sudden along came Claire. I mean, what's the lessons from that? Because that was not an easy sell. Government were rejecting the data, and actually we weren't initially looking at a ban. We didn't think that was politically feasible. We thought that much stricter regulation was the first step, but they weren't interested until Claire came on. So what does that tell us? Human face. Put a human in there, tug on people's heartstrings. Legitimate. I mean, it has to be legitimate. People aren't going to fall for something it's not legitimate, and you don't get more legitimate than Claire. There are cynics. After Claire had died, I actually went to a business luncheon with some very wealthy French entrepreneur who was trying to win over a heap of journalists for this wonder drug he was inventing to give you an instant tan without having to sit in the solarium all the time. He took us to a very expensive restaurant. I was the only health reporter. There was a bunch of business reporters in there who were more interested in the spreadsheets of what this drug was going to earn. And he made a joke over lunch at how much better things had got because Claire Oliver had driven everyone away from solariums and said, oh, she was only after 15 minutes of fame, but she's actually increased my bottom line. I lost it and stood up and said a few very unkind things and stormed out of the room. But that's the level of what you're up against sometimes. It's bloody horrible. Yeah, it was horrendous. That is what you're up against. But take a look at Claire Oliver, take a look at her mum Priscilla, and general public aren't quite like that. Another example, I think a few years ago, I can't remember how many years ago, last election cycle, so it'll be 4, I was chatting with somebody from one of the institutes who should remain nameless, and they were talking about a range of topics, but then hit on this incredible frustration they had. They've been trying for 6 years as a consortium of institutes around Melbourne to get funding for genetic testing for kids with rare diseases. Every year, they couldn't even get a look in. And so we kind of went, well, hang on, leave it with us. And we went off and we got a heap of these kids who have rare diseases, the Swan syndromes, without a name because they can't get diagnosed. So how can you name something? Put a couple of those up, wrote a story about how they only need, I can't remember what the amount was, it was a few million, to scan the genome and find out what's wrong with these kids so they can then be treated. We banged that on the front of the paper about 10 days out from an election. And we called both parties that night about 7:30, 8 o'clock when it's too late, the paper's getting printed, and said, we're smacking you both over the head in the morning because both of you have been asked for 6 years, governments of both colours have been in that time and you've done nothing. By 8:30 the next morning, both of them had contributed the money to pay for it. And it's been going for 4 years. They're now analysing and diagnosing more than 100 kids a year. And that was the power of timing. Hit them
in an election campaign and hit them with some kids that you can't say no to, and they didn't say no. Annie.
Just to say thank you both for defending the integrity. Thank you both for defending the integrity of Claire. We were all there. But I think, Nathan, just take assurance, what I've seen is the meter going that way with the issue of family violence. And it has been part of our lives for such a long time. And then it did take, a few high-profile events, and the meter has totally gone that way. There's research money, there are all commissions, there are, it's sort of a new way of teaching GPs about, how to look after people from family violence. So I just say to people, and with those preventative things, don't give up hope, the meter is shifting.
Thanks, Annie. Grant, could I ask you a question of outside the cancer field? So recently you've been involved in a very high-profile case with some conjoined twins.
Yes.
Which has, and probably a lot of people aren't aware of this, has actually involved yourself being really hands-on. Could you tell us the story and particularly reflect on, where almost intervention by, a journalist or the media can be positive?
I guess we'll protect a few people in this one. Good lesson for any journos listening is if you get the chance to be in a room full of lots of charity workers and surgeons all having a drink, you should sidle up and have a drink with them. A year ago, I was doing such things and got wind that a surgeon had been asked to help out with some conjoined twins and wanted very much to help them. So from then, it's a matter of me pestering them, saying, this sounds amazing. Are they coming out? And what help do you need? How is it happening? It kind of wasn't happening. And so then we're speaking to the hospital in question, getting them over the line, build up a plan, and it's following the story and trying to then help get the children here. Children's First, so there's a hospital trying to bring them out, Monash Children's. They get Children's First out because they are absolutely amazing at bringing children out from all over the world. They start trying to do all of this last minute for reasons I won't go into, but Monash Children's can't accept the twins and they're almost left. There's nowhere for them to go. We've agreed to help fundraise and pay for their surgery and bring them out. Children First are working really hard to get visas and all the permissions, but there is nowhere for them to go. So we speak to a few people that I know, that they know at the Royal Children's, have to send someone up a mountain to literally get Dad to sign off a consent form so that documents can be referred to the Children's. They look at them for a couple of years, yeah, we can help them. It's not going to be cheap, but we can help them and we want to help them. So then it's a matter of helping and working through visas and wanting to make the story as big as we can, tell it the best way we can, conscious of the fact, one, it's a great story, but two, we're morally invested in the story now and we need to raise a lot of money to pay for this surgery. So part of that meant that photographer, and I'd worked with Children First a lot. By that point, I'd been overseas with them before. So we went to Bhutan, which is bloody hard to get into if anyone's wanting to go there. But we did, and we helped bring them back. Children First did all the hard work, and we went over and we told part of the story over there, which is extreme to go to sit up in the top of the Himalayas, unable to breathe. But something I'll never forget. Then brought them back, but we broke that story, and unlike what we do a lot of the time, we didn't put a paywall up on that story. Anyone could read it. And we filmed a lot of footage out there, the photographer Alex and I, and we gave that out to all the other media networks and said, run this story and make it as big as you can. We didn't try to keep it an exclusive. We handed it out to everyone because we wanted to build momentum so the public would come on board and help fundraise. We got off the plane and the story got huge. We actually needed a security escort to get through the airport. And after a few texts, we'll find out the government has looked at how powerful that story has become and they've agreed to pay for the surgery. So surgery's paid for, still have a lot of care for them to spend months doing rehab and living in Australia. But I think in the first day or so, Stories generated $140,000 worth of goodwill from the public to help them. So it can make a difference, and it can make you feel good some days.
Okay, now I've got hands up all over the place, so if I can fit 3 questions in, provided they're brief. Here first.
This is week 2 of me working for a charity in the medical industry. Prior to that, I worked for a charity in the crime industry. And one of the things that we learnt, because we use the media all the time in crime, was that it had to be a human story. And that timing is really important too. And the relationship that we have with the Herald Sun is really, really important. So I just wanted to respond back to, and again, I'm not a clinician, so I don't know very much about the medical industry quite yet, that when we're talking about medical cannabis, is my response back to that, and I'm sorry it's not a question, is that you've got to humanise that question, and you've got to make it so that the community understands where you're coming from, which is what I learned in the crime industry. I'm sorry, I've taken up time, but it's probably a double question, but I just wanted to say that, and I think it goes to you, Grant, that if you can't get a hook for your story, it makes it a lot more difficult. Would that be right?
It makes it difficult, but I find if people have enough trust in you and you talk to them enough, you always find a hook. Might take you weeks to find one, but if you keep chatting to people and learn enough about something, you'll find a hook.
Okay, I did see another hand. Yeah, up the back, and then Elizabeth Johnson for the last question.
Thanks for the great talk. This question is actually for either of the Grant McArthur. So these stories that you report on pull at the heartstrings of the public, and they put a lot of pressure on scientists in the medical research field to publish more, or in pharmaceutical industries to become more productive and things. How do you think that affects the quality of medical research? And on top of that, how does that affect the public trust in the scientific field?
You want to go first? Yeah.
We might have different answers. This could get tricky. First of all, I find it's amazing how the upturn in pitching changes when it's grant writing season. But from my point of view, and hopefully I've been around the block enough times to realise it, I very rarely look at a piece of research and just report it. I generally talk to other people in the field to make sure how significant it is or isn't. I also look at where it's being put up, and you do have to be quite skeptical, but because you could report on 10 amazing pieces of research that are changing the world, and then the 11th time you might let your guard down and put something up, and it instantly undermines the previous 10 you've reported on, as well as your own credibility. So it is tricky, and it's really hard, particularly under deadline pressure. So nobody's perfect, but you do have to try to ignore deadline pressure and really scrutinise what you're reporting on.
Now, one comment I would make, that the power of the media is very, very relevant, I think, for us, here in 2018, because we put such a lot of emphasis now on directing our research efforts to what the community wants and what patients and consumers and patient advocates feel is important. And I think the media are very important as a part of that alignment between community expectations. We do have to guard against, the sensational and the extreme, that it doesn't divert us, but actually the net benefit is huge for community engagement in our research agenda that the media gives us.
Actually, I'll just add one more point. The slide I showed before with the 36 drugs that weren't getting listed, they were all for rare cancers, and that was kind of the point on that is, you don't want to have a league table of cancers, but there are some that get a lot more attention than others. And so there was a very big focus that we tried to do then to say, these are the ones that people are ignoring, that aren't getting the attention they deserve. And that was what those 36 drugs were for. Sometimes you do have to make a conscious effort to correct it, but it's a bloody hard story to tell.
Okay, final question from Elizabeth.
Okay, I'll make it really quick. Thanks, Brad. Congratulations on your efforts with the kids, and it sounds like a really heroic thing. The thing that's really quite alarming, though, I think, is the level of chance that's applied to these things. It's just a lucky chance that you happen to be talking to the right person and get something like that off the ground. And I wonder if, there's a case for maybe a strategy for having a more formal pipeline of communication between research teams, hospital institutional comms teams, and the patients, and what's your comment on that?
Obviously, it's in my interest too. We'd love to. Yeah, some places do it better than others. Some places understand it, and it can be down to changing of staff. I know one research institute didn't like the media, didn't deal with the media. They had a change in staff. I went along and did an off-the-record chat with all of their lead researchers, and in the end I said, each one of you tell me what you're working on and I'll tell you why that's a story in the public's interest and they should know about it. And we went around the room and it was great. I heard 5 or 6 front page stories in there and then had to pretend I hadn't heard about it. The interesting part for me was after I left and they were all somewhat energised, and over the next few weeks I read 3 or 4 of those stories in the Age and kind of banged myself on the head and thought, why did I give them the ideas for them to run off and give to my opposition? At least they got out there. But it would be great if there was more of a pipeline. It comes down to trust too. I mean, I'd suggest there are some great medical health reporters. I know I work with 2 of the best, with Lucy and Bridget. There are some other good ones around as well. I mean, the point is finding, and I think talking to people who are medical and health reporters and have been doing it, and that is their round. Because if you talk to them, it's in their interests that you live and die by your reputation. You live and die by doing a good job and being able to come back to people, regardless of whether you write what they like or write what they don't like. If you do it honestly and open, they'll keep talking to you. If you're dealing with people on the round, they have to deal with it in a proper professional way. And so it's about building up that trust, and there should be more open lines of communication, definitely.
Great. Well, we'll need to wind up there. I think what we've heard from Grant today is the value that the media brings, to the community and the work that we all do. And I think we've heard, in spades, the importance of integrity and professionalism in the way that media operate. And thank you for being a leader in that respect, Grant. Thank you so much.
Thanks.